So I'm going to talk a bit about our little meeting we had about 3.5-ish hours on Wednesday afternoon. And a lot of that focus, we heard a lot of the ALD and then the expansion of the ALD Alliance to move more national. And Elisa's been visiting many people on the Hill and into various states, as you heard. And now they are at the point where it's time to sort of go big. So I'm going to cover a couple different things that we talked about. So our purpose for this meeting really was to create awareness for people online and who were in the room on some national projects, and then to relay that to you. And so you heard about the Surge to Save Newborns, and I'll just talk a bit about the discussion. There's also the Newborn Screening Saves Lives Act. So I'll talk about that and the status of that nationally as well, and where it's kind of run into some roadblocks. Miranda alluded to the dissolution of the advisory committee, and it was this federal body that reviewed not only new conditions for the addition to newborn screening panels, but it also it gave federal guidance on newborn screening in general and helped drive programs towards some uniformity. Along the lines of, now that that was dissolved, the American College of Medical Genetics and Genomics has created what they call a newborn screening collaborative, and I'll tell you a little bit about that. And then lastly, we tied up with how we can work as a group to move the field forward in a cohesive way. We know that everyone has their different goals, and sort of newborn screening programs know what they want to do. The advocacy has their plans, the feds do what they do. And so how can we actually all work together and have a united front? And so the Surge to Save Newborns you heard about, so I'm not going to spend a lot of time on this. Minot Health was the group that did that assessment that came up with that $173 million figure. And the goal of this was to, starting back to 2015, there was a condition called Pompe disease that was recommended by the ACHDNC, and still all states are not screening for that, and that's at the 11-year mark now, right? And so the goal of this was really to get everyone online from Pompe all the way up to the latest editions, which were metachromatic leukodystrophy and Duchenne muscular dystrophy, and then plus 2 more conditions that are kind of in the pipeline. Okay, and so the way this would work is the states would request funds from this pool of money and be able to use them for purposes of becoming what we call RUSP compliant, or other purposes as well. But the goal was to get all states screening for all of the recommended conditions. And so when we were talking about this, so Rose Gallagher from Travere Therapeutics was the person who kind of introduced this along with Elisa to the group. And there was a webinar online back in January? Yeah, that introduced this as an entity as well. And so we discussed the fact that we need to have some flexibility in how these funds are used. There are some states that have a very, kind of a mechanism to do this. They have their own advisory committees. They have their own funding pools. There's methods that states need to follow to get the funding to implement new conditions. So sometimes the roadblocks are things like they don't have a lab, they need equipment, they need follow-up staff, they have to have new hires in the lab. There's a bit of a rotating door in newborn screening programs, and maybe they just need some new expertise in the lab. And so we were thinking about ways that this bill could include the fact that we would need some flexibility, not just sort of add the condition, but really add the things that are needed to add the condition. And so that was a major topic that we discussed. And then also we talked a lot about newborn screening is really moving towards advanced technologies. So we've all heard of genomic screening. There's a lot of projects going on around the world for that. And maybe we don't need every state to have a sequencing lab. Maybe we can think about how to regionalize, and can the funds be pooled so that, again, honoring that ultimate goal to become RUSP aligned, but yet do it in a way that might be a little bit different. So sort of thinking outside the box. And the other thing recently in some of the newer conditions is the fact that we don't just do this primary screen. We do that primary screen so we start with our population, we do the primary screen, and we winnow that pool down to babies that are at risk for the condition. But then a lot of times we need another test to really narrow down that population. And that's not new in newborn screening, but with these newer conditions, a lot of the times we need to have this higher tier test. And that's particularly true with metachromatic leukodystrophy. And we do it in New York State with CF as well, cystic fibrosis. The other thing we talked about was the bill should include some metrics to describe what success looks like, right? So we get this money, we do this, do we just add conditions? How do we get to that end goal? And what are the steps, the check boxes for success? And recognize that states have varying capacities to utilize these kinds of funds in programs like newborn screening. So the take-home message for this is that we want to ensure that all babies get screened for all conditions, independent of the program, whether it's a single or a regional type lab, and the methodologies that are used. And so stay tuned, and maybe we'll report on how successful this is in a year or two. The other thing we talked about was something called the Newborn Screening Saves Lives Act. How many people know what that is? Anybody know what that is? Okay, so this is well, you guys know. Come on. Newborn Screening Saves Lives Act was passed back in 2008, and it basically outlined a lot of things for newborn screening on a national level. So that was what established the advisory committee, really sort of codified the advisory committee. There were sort of advisory committees before that, but this sort of set the tone for it. Also gave funds to places like CDC, the Centers for Disease Control, and HRSA, Health Resources and Services Administration, to advance newborn screening. It established the Hunter James Kelly Research Institute in Buffalo. So there were a lot of sections to this law that sort of really governed newborn screening. So it was reauthorized kind of at the last minute. I think it was December in 2014 for another cycle. And again, it had a set of sections that dictated what newborn screening programs should do and what feds should do in order to create an environment where newborn screening is centralized. Then certain folks in the Senate came up with some concerns about informed consent for storage. So newborn screening programs typically store dried blood spots. Some don't, some get rid of them right away, some store them very long term. And if you go on the New Step site, you can actually look at what your state storage policies are. So there became this concern about genetic privacy. There were some lawsuits, this worry about parents consenting to store their baby samples. And then also, of course, down the stream from that is about research, how the baby's specimens are actually being used. And so there was this piece called Section 12 that was sort of added in 2014. And basically, there is the Office of Research Subjects Protection had to reestablish what the common rule was, and the common rule dictates human subjects research. And so that's also a federal office. And so it was kind of agreed that it's reauthorized. We'll wait to see what the common rule updates were. And this information was in what was called Section 12. So we went about our business. We had conferences on residual dried blood spots and what they're done, how they're used in programs, and the common rule was reauthorized again. And basically the take home was that residual dried blood spots sitting in a cooler somewhere are not human subjects, because that was sort of the point that people were arguing. So the common rule was reauthorized, everything was cool, but these folks didn't like the new common rule. So even though we did all this waiting and reestablished what the common rule was, they still weren't happy. And so here we are in 2026. The Newborn Screening Saves Lives Act has still not been reauthorized. The other thing so the Newborn Screening Coalition was sort of waiting to see how this all played out, and the National Academies established a report on newborn screening, came out on May 1st. And it came with 9 recommendations for sort of federal oversight of newborn screening, kind of along the lines of similarities to what the Newborn Screening Saves Lives Act, kind of similar recommendations, and that there should be this overarching federal recommendation. So in the interim, a lot of people have worked with the entities in the different senators' offices, and the staffers come and go, and sometimes you get people who kind of pay attention to you, sometimes you don't. So the question becomes, how long do we wait for traction? How long do we wait for the right person to come in this office so that they can understand what we're trying to say? And at the end of the day, most newborn screening really doesn't use identifiable samples. We don't go in the cooler and pull out, Bobby Smith's sample and use it specifically, unless we have permission from the parents. And so most of what we do is really using samples that are de-identified. We have nothing but the 9-digit code that's on the edge of the filter paper. The other thing that we, has that actually been given to these folks to kind of understand or come see what this looks like. The other thing that we talked a lot about was defining what research is. So in newborn screening, we have to obviously develop new methods, right? We talked about implementing new conditions. You can't just here it is, right? We have to do research, and we have to do them on the newborn screening specimens that we have. And so is method development research. We have to validate new assays. Once we kind of establish the method, we have to sort of test it in our population and make sure that the assay works. We don't want to do it wrong, right? We have to make sure we get the right answer. And then once we actually start screening, we actually take look-backs to see how well are we doing. Do we improve the assay? Do we come up with a second-tier test to make the screening better? And then we also have to use specimens sometimes for proficiency testing. That's a federal rule. We have to do that in order to work in the laboratory. So is this all research? We need to really define what the folks who are concerned about see as research. And we also should identify what de-identified really means. If we work very hard and we do a lot of genomic sequencing and we have a reference sample out there, we can identify a sample and say that they're linked. And if we know the identity of either person, you can sort of come up with who this individual is who has this de-identified sample. So, there is some truth in the fact that de-identified might not truly be de-identified. And I think at the end of the day, we just need transparency, and we need to educate people on what we're doing. So we talked about weighing the feasibility of using an opt-out model. If you don't want your baby sample stored, and we do this in New York, we allow the parent to send in a note and tell us to throw it away, and we do. So we need to kind of cite, we need to work through parental responsibility and balancing parental rights of privacy. And this is where a lot of this comes from. It's parental rights to, luckily the folks that are detracting to this don't disagree with newborn screening, but they are concerned about what their rights are after the sample is used for screening. And then going back to the Saves Lives Act, we had House support. It came across all the Google News alerts. There was a bill that was put forth in 2021. It had a lot of the components of the original act, but a lot of structural changes to the advisory committee, which was dissolved on April 3rd via an email. Thank you for your service. Your advisory committee is no longer operative. So in an era of mistrust of government, newborn screening programs may, at the end of the day, just have to come up with a way to get consent from parents. And maybe today it's a little bit easier than it was in the past. With new technology, can you do things electronically? Can you easily translate to different languages? So we need to sort of start thinking about that as well. So moving on to the next thing that we talked about was the Federal Oversight Committee, the Advisory Committee. And so Susan Tanksley gave a really nice talk on the things that sort of we felt like we lost, like the community actually lost. So we lost central leadership. The feds tell us what they think. It goes through this process. People have input. They come up with a recommendation. The Secretary of Health and Human Services signs off. And then, lo and behold, it becomes a condition on the RUSP, which is the Recommended Uniform Screening Panel. So we lose that guidance, that kind of whole mechanism that we got used to. Not only, as I said, the advisory committee did the sort of RUSP analyses, but they also gave us benchmarks for specimen collection, for timing, and for reporting. They also gave us guidance on how to do short and now long-term follow-up, following these kids beyond a diagnosis. How well are we actually doing as programs? We need to follow these kids beyond the diagnostic and see, did we really make a difference in their lives? No one has an answer to that question. It's anecdotal. How do we kind of put that kind of a structure in place? Issues around consent guidance. Again, we just talked all about that. It will actually, may, without surge to save newborns, end up with a slower adoption of newer technologies and programs, and improvements in the whole system were just right there. We were streamlining the nomination process. There were a bunch of things going on, and that all stopped. Patients really lost that federal voice and a forum for them to present their concerns. And as Natasha said, there's now a public health accountability gap. So the answer to this kind of vacuum is that the American College of Medical Genetics established what they're calling a newborn screening collaborative. And they had talked to HRSA. So HRSA is the federal body that sort of governed the Federal Advisory Committee. So they talked to HRSA about their plans, and then they moved forward with initiating this. And they had a roundtable back in August, and just recently they sent out an email to, I'm not sure who, if it was ACMG leadership or others, about their plans on moving forward with coming up with a submission process for new conditions. As Miranda said too, MLD and Duchenne were added via a federal register, because these were all the way through evidence review at the May meet. So the advisory committee was canceled in April. At the May meeting, we were going to vote on those two conditions. And so they came up with a way via the federal register for the Secretary of Health and Human Services to officially add those to the RUSP. And they said that this was just a one-time use. They weren't going to continue this method. So the charter for this ACMG group is similar to the advisory committee, and the hope is that evidence review is sped up, that they can do multiple at a time and potentially add groups of conditions by, say, a technology rather than a one at a time. So all of this is in flux, but it is moving forward, and we'll see how it pans out. They also noted that if the feds come up with a mechanism, they will back away, that they're not interested in having two parallel systems to do this. And then one of the questions we talked about, and one of the real sticking points for advocacy groups, is how to nominate samples. So Joe has worked on nominations, people have worked on these for ALD, and they're incredibly onerous. They're very long documents, you have to have a lot of experts, it's costly. And so do we change that? Do we take this as an opportunity to alter that process and make it a little bit easier? And so these are the things that the ACMG is kind of looking for. So at the end of the day, we had these discussions, and then it's like, okay, so what do we do, right? What do we do with all of this? We know all these things are swirling around our heads. So one of the main questions is, who do we want to engage? And we decided we obviously need newborn screening, right? Because they're kind of big players. Advocacy groups, large and small. Policymakers, we really need to have people kind of understand what we do. We were talking at the table where we tell people we do newborn screening, and they look at us like, oh, that sounds nice. People have no clue. And so how do we tell people what we really do outside of dragging them in the lab and showing them this is what we do? We also need federal groups, and even our adversaries, even folks that are anti-screening, anti-specimen storage, to really be at the table and talk about how we can all work together to move this forward, because at the end of the day, it is a good program, right? We feel like we do good for the nation's children. So what are our initiatives? And I'll quote Natasha again. I'm not sure, she's probably not online, but Amy can tell her. Her quote was, "The system works when all are informed and connected." And I think that's the mantra we need to take home from this. So we need to attribute value to all the viewpoints out there. So do we do it by education and awareness? We've been talking about this forever. Like, we need to educate. If we just educate, then people will understand. And I don't know that that's always true, because some people don't want to be educated. So how do we just do awareness? We think we need to really define definition, to define what we're talking about, and everyone needs to define it the same way. We need all the groups in this space to send a cohesive message. If you go to the legislature, you go to the Hill, often newborn screening and rare disease research get binned together, and they think we're all the same people, and we're not. Sometimes we're not. So we decided that we would try and schedule some meetings every 6 to 8 weeks, And Amy and I will be in touch with you and others and try and put something together so that we have a newborn screening strategic plan. So that was 3.5 hours and hopefully not that long. If you have any questions, you can you can tell me now or catch me later. I'll be here all day. All right, thanks.